Hello and welcome to the webinar, Optimizing Patient Outcomes Using Drug-Eluting Stent Technology. This program is provided by North American Center for Continuing Medical Education, LLC, and it is supported by an educational grant from Biotronic. I'm David Kinzeri, Director of Interventional Cardiology at the Piedmont Heart Institute in Atlanta, Georgia, and Chief Scientific Officer of Piedmont Healthcare. And I'll be your presenter today with two of my longstanding friends and colleagues, Drs. Ron Waxman and Jim Hermiller. Let's begin with revisiting stent design and the evolution of drug-eluting stent technology to bring us to contemporary comparative drug-eluting stent data over the past year with regard to newer drug-eluting stent technology. My disclosures are related to research and grant support and minor consulting honoraria from Medtronic, Boston Scientific, and Biotronic. Within the past year, as we've celebrated the 40th anniversary of groundbreaking work by Professor Andreas Grünsig in balloon angioplasty alone, we're reminded that the history of interventional cardiology has been a very storied path of evolution in stent and device technology, in advancement of evidence basis and rigorous clinical trials research, and also in the advancement of technical skill sets and procedural technique. In 1987, the first stent implantation occurred in Sao Paulo, Brazil, with Eduardo Sousa and colleagues from Sao Paulo, Brazil, shown in this photograph, along with the innovators Julio Palmez and Richard Schatz. And this groundbreaking technology was only further advanced only about a decade later, with at the same center the very first implantation of drug-eluting stent technology, a first-generation sirolimus-eluting stent implanted in patients that would truly revolutionize interventional cardiology and create a large impact on public health and a change in the paradigms or the standards of care for patients with both simple and complex coronary artery disease. It stands, however, that in our history of interventional cardiology, we've had a psychology that whatever is next around the corner is always going to be better, and that something better is going to be an advancement in the care of our patients. And with that enthusiasm, however, it's on occasion been tempered by realities with further rigorous study to selected technologies or techniques not advancing the benefit of our patients. One such example has been scaffolding technology, for instance, which, although very promising, at least still as of to date, has not demonstrated superiority or in many instances even clinical superiority compared with conventional contemporary generation drug-eluting stents. In fact, in many ways over the past few years, we've observed the best outcomes with drug-eluting stents that we've ever witnessed before. And there appears to be quite a similarity in the outcomes with existing drug-eluting stents, such that many clinicians perceived a potential class effect of drug-eluting stents, meaning that across different stent technologies and designs, that there may be similarity in clinical outcome and especially with regard to both safety and efficacy. And in some ways, then, over the past few years, the interest in drug-eluting stent technology in clinical trials has waned, assuming that we've plateaued in the benefits that we could achieve with drug-eluting stents and that perhaps we could not incrementally advance care beyond this. And in many ways, the focus has turned to transcatheter valvular therapies and other structural heart disease technologies. But this has been very different over the past year alone. For example, at the TCT meeting, in which the headliner was Back to the Future, in which we've now had a renewed interest in the potential of drug-eluting stent technologies. And we've shown in recent contemporary trials that we'll review in the next few moments that we actually can breach that ceiling or that plateau of safety and efficacy with newer stent designs and newer stent technologies. Why might we want to advance drug-eluting stent technology when seemingly we've optimized safety and efficacy? Well, for the course of stent technology since their initial introduction, these technologies have been and continue to advance to resolve current biological and mechanical complications, enhance performance such as deliverability for operators, and in some instances optimize fabrication or the development of stent technologies as well. And this latter issue, for example, could have potential cost savings implications. And as I've also shared, that while what we think might be better has not always been the case, and With newer data that we'll soon discuss, we've learned that the metallic footprint within the vessel wall, not only with regard to strut thickness, but even strut width, is very important and may be an influential determinant of clinical outcome. We've also learned that across the introduction of non-polymeric stents and bioresorbable polymer and durable polymer drug-eluting stents, that the stent coatings themselves may not necessarily be thrombogenic in all cases, but they can be detrimental in selected instances when we don't understand the chemistry, when the polymers might contribute to late neointimal hyperplasia or chronic inflammation that could result in outcomes such as stent thrombosis or late target lesion revascularization. On the other hand, selected bioresorbable polymers could also be injurious if the degradation is an energy-yielding process that could create inflammation over long-term follow-up. And similarly, drugs, anti-proliferative drugs, can be beneficial, but they can also impair healing and repair. So one of the issues that's become increasingly difficult in comparative drug-eluting stent trials is that the opportunity to demonstrate benefit is increasingly challenging. And this is in part because the outcomes now, as I've introduced, are so good and the event rates are so low that comparative trials require very large sample sizes to demonstrate differences between two comparator drug-eluting stents. Non-inferiority trials are commonplace, but in some instances, perhaps we've had too much non-inferiority and not enough progress in advancement because of wide statistical margins or the statistical design of these clinical trials. And further, because of the difficulty in demonstrating benefits in large clinical trials and because of the costs and the logistical challenges of performing such large studies, there's been instead a shifting emphasis on evaluating stents with preclinical assessment and in vivo imaging, such as with OCT imaging and evaluating strut coverage, or with physiology. Nevertheless, each design element of a stent can be considered separately, rather a comparison of a polymer that may be biodegradable versus a permanent polymer, or thin struts or ultra-thin struts versus thicker strut stents, or differences in stent design. But it may be, too, that the addition of all of these selected elements contributes to an advantage that in aggregate results in a clinically meaningful advancement. And this may be the case in some of the more recent comparative drug-eluting stent trials that we'll review tonight. From a drug-eluting stent perspective, then, what has motivated also on a clinical grounds the advent or the continued iterative development of drug-eluting stents is the observation that with contemporary drug-eluting stents, both first generation and even current generation permanent polymer drug-eluting stents, that there is opportunity for improvement. We still observe over long-term follow-up a persistent at least 1 to 2% annualized increase in late target lesion revascularization, so-called late catch-up phenomenon, and we continue to observe, albeit low in their frequency, very late stent thrombosis events. There have been many advances in the design of drug-eluting stents, including thinner strut designs, stent design modifications, improvements in polymer biocompatibility, and also more recently the development and introduction worldwide of bioresorbable polymers for drug-eluting stents. And it's the bioresorbable polymer component that allows controlled, simultaneous, or subsequent dilution of the polymer material, eliminating the stimulus for chronic inflammation, and at least hypothetically restoring the characteristic or the stent phenotype to that of an inert bare metal stent over long-term follow-up. Until recently, however, previous comparative studies had reported statistical non-inferiority between trials comparing permanent polymer drug-eluting stents and bioresorbable polymer drug-eluting stents with regard to primary endpoints such as target lesion failure, and the benefit over long-term between these two stent types has been inconsistent. One more recently studied bioresorbable polymer drug-eluting stent is the Orsiro ultra-thin strut stent system from Biotronic. This is a stent that is characterized by an ultra-thin strut cobalt alloy stent with a strut thickness of 60 microns and a polylactic acid polymer that is bioresorbable over an approximate 2-year period. The drug-eluting stent elutes the well-characterized anti-proliferative agent sirolimus, which is well proven in its safety and its anti-proliferative capabilities. And altogether, the stent is one that has been recently evaluated in a series of comparative trials evaluating the Orsiro stent versus not only durable polymer Xience stents, but also even non-polymeric drug-eluting stents that we'll review in the next few moments. The pivotal trial under FDA guidance in the United States for the Orsiro stent was termed BIOFLOW 5. BIOFLOW 5 was an international prospective trial in which patients were randomized in a 2-to-1 fashion to either the Orsiro stent or the thin strut durable polymer Xience drug-eluting stent with the drug everolimus. The patients from this randomized trial, which totaled a sample size of 1,334 patients, were then combined with an additional group of patients from 2 previous randomized trials comparing Orsiro and the Xience stent, combined all together to create a Bayesian study population of 2,208 patients to assess in a non-inferiority design, the 12-month endpoint of target lesion failure, which is a composite of cardiovascular-related death, target vessel-related myocardial infarction, and ischemia-driven target lesion revascularization. In this trial, patients were enrolled in 13 countries in North America, Israel, Asia, Europe, Australia, and New Zealand. 12-month follow-up was completed in May of 2017, and we had 2-year follow-up, which we recently published and reported, and which I'll share with you in this program. 2-year follow-up completeness in approximately 96% of the study population. In the trial, BIOFLOW 5, we observed in the randomized component a statistically significant difference in procedural success, defined as the achievement of a less than 30% residual stenosis within the target lesion using the assigned study stent and without the occurrence of in-hospital major adverse events. This significant difference in procedural success favored the Orsiro stent, and it was driven principally by a significant difference in periprocedural myocardial infarction with the Orsiro stent compared with the durable polymer thin strut Xience stent. Specifically, the rates of in-hospital myocardial infarction were 3.9 versus 6.7% for the Orsiro and the Xience stents respectively, achieving statistical significance. This was again driven principally by periprocedural myocardial infarction by a pre-specified per protocol definition of a CKMB greater than 3 times the upper limit of normal. But it's important to note, too, that we also observed a significant difference even when escalating to higher levels of periprocedural cardiac enzyme elevation by the criteria of more than 5 times the upper limit of normal. Aside from myocardial infarction, however, 30-day outcomes were statistically similar and very low between the 2 treatment groups. However, at 12-month follow-up, the trial's primary endpoint of target lesion failure was significantly different in favor of the Orsiro stent, a difference in target lesion failure of 6.2 versus 9.6% for the Orsiro and the Xience stents with a p-value of 0.04. And we observed through 1 year a continued significant difference in the outcome of target vessel-related myocardial infarction, again favoring the Orsiro stent. The rates of cardiac death were very low between the 2 stent groups, as well as the rates of target lesion revascularization, which were notably only 2% for the Orsiro group and 2.4% for the Xience cohort. At 2 years of follow-up, however, we were very interested in this trial in observing whether the difference in target lesion failure was maintained through 2 years of follow-up, and further, might the differences in myocardial infarction and or other endpoints persist, or might new endpoint differences be observed. Through 2 years of follow-up, recently presented at the TCT Scientific Sessions and published simultaneously in the Journal of the American College of Cardiology, we observed that the difference in target lesion failure that favored the Orsiro stent was maintained through 2 years of follow-up. Through 2 years, a significantly lower event rate of 7.1% versus 11.1% for the Xience stent. Further, the rates of target vessel myocardial infarction also persisted and were significantly different through 2 years of follow-up. But what we also observed was not only a significant difference in the rate of periprocedural myocardial infarction, which was lower for the Orsiro stent compared with Xience, but also a significantly lower event rate with regard to spontaneous myocardial infarction. That is represented in this figure through 30 days as previously described. We observed a statistically significant difference in the occurrence of myocardial infarction that favored the Orsiro stent, But in a landmark analysis between 30 days and through 2 years of follow-up, we also see a significant difference in target vessel-related spontaneous myocardial infarction, roughly a 3-fold difference that is higher in the Zients cohort compared with the Orsiro group. Moreover, perhaps unexpectedly, we observed a significant difference emerge in target lesion revascularization through 2 years follow-up. Specifically, as at 1 year, the rates of target lesion revascularization, you will recall, were very low and did not statistically differ between the 2 stent types. And yet, over 1 to 2 years of follow-up, we observed an emergence of a difference in late target lesion revascularization, with a continued accrual of target lesion revascularization rates in the Zients cohort compared with a leveling or plateau of TLR in the Orsiro cohort, such that at 2 years the difference was 4.8 versus 2.5%, with a p-value of 0.04. Represented graphically in another view of the landmark analysis, again, no significant differences and very low rates at 1 year of follow-up, but a nearly 3-fold difference in late target lesion revascularization between 1 and 2 years of follow-up that again favored the Orsiro stent. And further, against the background of observing significantly lower target lesion failure at 2 years, significantly lower target vessel-related myocardial infarction at 2 years, and further, as recently presented, significantly lower target lesion revascularization, we further observed a significant difference in the occurrence of late and very late stent thrombosis that again favored the Orsiro stent. Specifically, by the definite and indefinite probable criteria, the occurrence of late and very late stent thrombosis events, that is, events occurring after 30 days and within 2 years of follow-up, were 0.1% for the Orsiro stent and 1.0% for the Zients stent, with a p-value of 0.045. It's important to note, too, that these differences were observed against a quite similar rate of dual antiplatelet adherence at 2 years of about 45% in both the Orsiro and the Zients treatment groups. Altogether, then, these results with an ultra-thin strut bioresorbable polymer drug-eluting stent invite the opportunity to revisit what has been termed in the past the thin strut hypothesis, or perhaps now with these data comparing an ultra-thin strut stent versus a thin strut stent, the ultra-thin strut stent again having a strut thickness with the Orsiro of 60 microns and 81 micron strut thickness for the Zients stent, that perhaps this is more than a hypothesis. Specifically, it's been well documented in preclinical studies as well as in subsequent human clinical trials that thinner struts may result in less inflammation, vessel injury, neointimal hyperproliferation, and thrombus formation compared with thicker struts. And when we consider the past 15 years of drug-eluting stent iterative development, from first-generation thicker strut stainless steel stents to thinner strut cobalt alloy stents to ultra-thin strut cobalt alloy platforms, we've observed this progression to be also paralleled with a lower rate of target vessel-related myocardial infarction and in some instances a tendency towards lower stent thrombosis. More specifically, as we've moved from strut thickness with stainless steel stents from 130 to 140 microns to chromium alloy stents like the Zients stent at 81 microns to 91 microns, this has translated alone to a 40 to 80% reduction in both procedural and late-term target vessel-related MI. In the BIOFLOW 5 trial at 2 years, the 20 micron difference between the Orsiro stent and the Zients stent then is similarly associated with an approximate 40% reduction in target vessel-related MI at 2 years, a nearly 50% reduction in target lesion revascularization, and a more than 50% reduction in the occurrence of late and very late stent thrombosis. This concept of an ultra-thin strut stent perhaps being associated with lower ischemic events is also supported by a recent independent analysis in which nearly 11,600 patients who were included in randomized trials comparing ultra-thin strut versus thicker strut second-generation drug-eluting stents demonstrated a significantly lower incidence of target vessel-related myocardial infarction, and further a trend towards a lower rate of stent thrombosis with the ultra-thin strut drug-eluting stents. More recently, too, and as I've introduced earlier in the program, the Orsiro stent has not only been compared to durable polymer drug-eluting stents, but to a polymer-free biofreedom drug-eluting stent in the recent SORT-OUT-9 trial. SORT-OUT-9 was a study that was performed at 4 centers in the country of Denmark, enrolling 3,151 patients. This was a study in which follow-up of this trial was derived from a national healthcare database rather than the more traditional methods of clinical trial follow-up. But in this trial, patients were randomized to the biolimus-eluting polymer-free biofreedom stainless steel thicker strut stent, or alternatively to the ultrathin strut bioresorbable polymer or Orsiro stent. The primary endpoint of this trial was target lesion failure. And again, these data that were presented as a late-breaking trial at the TCT session demonstrated that the trial did not meet its non-inferiority endpoint at 1 year of follow-up. Specifically, the event rate for the biofreedom stent for target lesion failure was 5.2%, 4.0% for the Orsiro stent, and this numerical difference did not achieve statistical significance for non-inferiority. Moreover, this difference between the drug-eluting stents was driven principally by a statistically significantly lower event rate of target lesion revascularization that favored the Orsiro stent. At 1 year, the event rates were 3.5% versus 1.3% for the biofreedom and the Orsiro stents respectively, with a p-value of less than 0.001. By subgroup analysis, too, in this trial, although not consistently achieving statistical significance with regard to target lesion failure, it's clear that the point estimates more consistently favored treatment with the Orsiro stent compared with the biofreedom polymer-free drug-eluting stent. Aside from the SORT-OUT-9 trial, another recent trial also presented as a late-breaking session at TCT and simultaneously published in The Lancet that involved the Orsiro stent was the BIONYX trial. The BIONYX trial was an international multi-center clinical trial randomizing 2,488 patients in Europe to either the Resolute Onyx drug-eluting stent, a zotorolamist-eluting stent, or alternatively the Orsiro stent, and evaluating the primary endpoint at 12 months of target lesion failure. In this trial, at target vessel failure, and in this trial for target vessel failure at 1 year, the event rates were nearly identical and therefore statistically non-inferior between the two stent types, 4.7 for the Orsiro stent, 4.5% for the Resolute Onyx drug-eluting stent. Moreover, with regard to the individual components, the component elements of target vessel failure at 1 year, the rates of cardiovascular death were low and did not statistically differ between the two groups. Target vessel myocardial infarction rates were identical at 1.5% between the two stent types, and clinically driven target vessel revascularization was generally favorably low and almost numerically identical between the two drug-eluting stents. What did emerge in this trial was an unexpectedly lower rate of stent thrombosis that was quite unusually favorable for the Resolute drug-eluting stent at 1 year. Specifically, the event rate for definite probable stent thrombosis for the Orsiro stent at 1 year was 0.7%, so very consistent with what we have seen in previous clinical trials and quite favorably low, with most events occurring within the initial 30 days of stent implantation. But it was exceptionally low for the Resolute drug-eluting stent of 0.1%, an event rate that we've not seen before in previous clinical trials, and is a very favorable, and both of these favorable event rates are observed against the background of a fairly complex patient population. What will be interesting to also observe in the BIONYX trial is the longer-term follow-up of this study. This is because the BIORESORT trial was an additional study that also compared the sirolimus-eluting Orsiro stent versus the zotorolamist-eluting Resolute stent and the everolimus-eluting Synergy stent. This trial was presented for 2-year follow-up recently this past year at the Euro-PCR scientific sessions in Paris as a late-breaking clinical trial, and also simultaneously published in the journal Eurointervention. Through 2 years of follow-up in this trial that included in an all-comers clinical trial design 3,514 patients who were evenly randomized to the 3 different stent types, there were overall no statistically significant differences in the outcome of target vessel failure between 2 years follow-up. But it's hypothesis generating, at least, to observe that between 1 and 2 years of follow-up, that is over late-term follow-up, a significant difference in target lesion failure and a significant difference in target lesion revascularization was observed, favoring the Orsiro stent compared with alternative stent designs. Specifically, the difference between the zotorolamist-eluting Resolute stent and the Orsiro stent was statistically different both between 1 and 2 years of follow-up for both target lesion failure and target lesion revascularization. These findings are somewhat analogous to the observed differences at 2 years in the BIOFLOW 5 trial compared with the Zion stent, and whether these differences persist or continue to diverge in the BIONYX trial will be a point of topical interest. So to date, as we almost enter into 2019, we've learned from drug-eluting stents over the past year, consistent with previous observations, that drug-eluting stents are associated with a profound durable reduction in the need for repeat revascularization. And indeed, they possibly are associated with lower rates of myocardial infarction and stent thrombosis than bare metal stents. And this has also been a secondary reminder from non-polymeric clinical trials of drug-eluting stent trials in high bleeding risk patient populations. Further, what we've also recognized with the improved safety of existing drug-eluting stents is that long-term commitments to dual antiplatelet therapy may not be clinically required, especially at least for selected patients with high bleeding risk clinical criteria, and a number of ongoing clinical trials evaluating abbreviated dual antiplatelet therapy regimens with both permanent polymer and bioresorbable polymer drug-eluting stents are being performed or have been conducted. We've also recognized, too, as implied by these clinical trial data presented in this program, that there are emerging differences in safety and efficacy endpoints between drug-eluting stents, that we're no longer necessarily plateaued with regard to a class effect of safety and efficacy with drug-eluting stents. And further, that the story of safety and efficacy with drug-eluting stents does not simply stop at the primary endpoint of a clinical trial. And we've observed through longer durations of follow-up the continued emergence of new differences between drug-eluting stents as observed in some of the clinical trials presented during this program. What we've also recognized, too, with the safety and efficacy of existing drug-eluting stents is that we're moving into new complex clinical indications and lesion complexities that previously were not routinely approached with interventional cardiology, including unprotected left main disease, an increasing interest in chronic total occlusion and other complex anatomy, including calcified disease and bifurcation disease. We've also entered into an issue of completeness of revascularization, in part driven by hemodynamics and fractional flow reserve assessment, and newer and ongoing trials in very complex patients, such as those not deemed eligible for coronary artery bypass surgery with very complex coronary artery disease. And this has all been the result of not only an evolution in stent technology, but also an evolution of skill sets in clinical practice combined with drug-eluting stents. What we've also observed, too, as I've implied earlier, is the emergence of the risk associated with dual antiplatelet therapy over long-term follow-up for selected patients with high bleeding risk criteria. And interestingly, in randomized clinical trials comparing drug-eluting stents versus bare metal stents in selected clinical trials and in highly selected patients, it appears in recent meta-analysis, for example, that the outcomes of target lesion revascularization, of myocardial infarction, and even stent thrombosis may favor drug-eluting stents compared with bare metal stents. It's raised the issue in clinical practice of whether there is even any persistent role for bare metal stents in patients who require short-term dual antiplatelet therapy or who have a need for upcoming non-cardiac surgery. In fact, in an editorial authored by Dr. Dean Kariakis that highlights the limitations that we've had in the past of studying bare metal stents and questions whether there is a role for bare metal stents in clinical practice today. And in fact, this was recently also underscored in the European Society of Cardiology guidelines, in which, when review of the data, that more recently there is a recommendation from the European guidelines to use drug-eluting stents over bare metal stents with a Class 1A indication for PCI, irrespective of the clinical presentation, the lesion type, of whether patients have a requirement for upcoming non-cardiac surgery, independent of the anticipated duration of dual antiplatelet therapy use, and in the setting of concomitant oral anticoagulation. So in summary, evolution, as I've implied, is inherent to interventional cardiology, and it's been characterized by a more than 40-year history of an entrepreneurial spirit and a passion for experimental research and dedication to evidence-based practice. But until recently, the history of interventional cardiology has been consumed by this anticipation that what's next is going to be better than what we have today. And this has not always been the case, as we've been reminded in more recent examples. But with the existing technologies and with existing technique in interventional cardiology, we're realizing the best outcomes with PCI than ever reported. And yet still, the recent trials demonstrating differences between drug-eluting stents remind us that there remains an opportunity to develop newer drugs, newer polymers, newer stent delivery systems, the selected attributes of each that might confer incremental clinical and performance benefits above the existing technologies that we have available to us today. What we do need to do, however, is to level set or reset our expectations with regard to when and where and how these differences in clinical trials might be observed, whether there are differences in periprocedural myocardial infarction, whether there are differences in late spontaneous myocardial infarction, or whether there are differences alone in target lesion revascularization or stent thrombosis, more traditional endpoints to which we're accustomed to in interventional cardiology. Altogether, then, the introduction of newer technologies for drug-eluting stents enables us to address existing challenges, to test strategies or new advantages, such as shorter durations of dual antiplatelet therapy or the role of these technologies in very complex anatomy and clinical indications, and to demonstrate a value of these newer technologies that informs our current dilemmas in existing practice. Thank you. At this time, I'm going to introduce Dr. Jim Hermiller to address differences in indications for drug-eluting stents.
Thank you, Dr. Canzeri. I'm Jim Hermiller, and I'm from St. Vincent Heart Center and St. Vincent Medical Group in Indianapolis. Here are my disclosures for your reference. My goal today is to examine the current FDA-approved drug-eluting stents and their indications. The three FDA-approved devices in the U.S. include the Abbott's Xience Sierra device, Medtronic Resolute Onyx, and then Boston Scientific Synergy. The Abbott device is a cobalt chromium metallic platform with everolimus as the active drug and a permanent fluoropolymer. Medtronic, the Resolute Onyx device, has a cobalt platinum iridium alloy and is a zodorolimus-based device. And then finally, Boston Scientific, of these three, is the only with a bioresorbable platform, and it's platinum chromium with everolimus as the active drug. Well, as we look at the indications for these various DES in the U.S., the indications are very similar. Diabetes, symptomatic heart disease with stable or unstable presentation, de novo, coronary lesions, and at least for the Sierra platform, chronic total occlusions. But it's interesting that most of what we treat today really doesn't have an indication. For example, STEMI, multivessel disease, bifurcations, left main, in-stent restenosis, high bleeding risk. And in fact, if you look at the indications for the approved devices, the length of the lesion that we should treat, generally shouldn't be over 32 to 34 millimeters in length. And, we almost every day are treating lesions much longer than that. Well, this really begs the question, what will the indications look like for an ultrathin device, like the Orsiro device? What's it going to look like? We know about this from Dr. Canzeri. There's a very deep data, robust data from the international experience with the device. And now there's recently published FDA pivotal data that show the device to be very safe, very effective, and in fact, compared to approved device here in the U.S., the target lesion failure rate is superior with the Orsiro device. Well, if we look at the CE mark indication, we might get a bit of insight into what we're going to see once it comes to market here. The CE mark indication is for proven coronary luminal diameter in patients with symptomatic ischemic heart disease due to de novo lesions and also in-stent restenotic lesions with lengths of 40 or less and reference diameters between 225 and 4 millimeters. We'll have to see whether the FDA indication includes in-stent restenosis or diabetes, but we know some of the devices already approved do and don't. What we do know is that when choosing a device, there are really attributes of this that are very favorable. That includes very high flexibility and vessel conformability, low crossing profile, and this is all not at the expense of radial strength, as it has very good radial strength. And I think one of the most important attributes that we all want in our stents is to have a very deliverable device, and this device is exceptionally deliverable, and the data would speak to that. Some of the potential applications would be in small vessels, particularly here where a lower metal burden may be beneficial. There's only so much headroom in a small vessel for neo-intima and restenotic material, and the smaller the profile of the struts, the better. Distal anatomy with extreme tortuosity. These can be treated with this device due to its high flexibility and conformability. And then lesions that are very tight, very stenotic. It has a very low crossing profile and may get to a lesion when other stents can't and then cross it when others can't either. Now, as we sort of compare and contrast these devices, I wanted to just give you a little data, information that's practical. How do these compare and contrast? There's Synergy, Onyx, Science Year, and Orsiro. We already talked about the stent material and the drug polymer that makes up these devices. I would say just to remember that the Orsiro is a bioresorbable PLLA polymer, but it also has an amorphous silicone thin covering on which the PLLA is based, and this, as the PLLA bioresorbs, this is left behind. It's very inert and is not reactive. In terms of the strut thickness, it's the thinnest strut. As you can see, the 225 to 30 is 60 microns, so very thin, 0.024 inches, right? So very thin. The stent geometry is shown here, and it has a double helical pattern that the Orsiro probably is important in the conformability as well as the flexibility of the device. The diameters are very similar to Synergy, Onyx, and Science, although Onyx has a 4.5 and 5.0. The others don't. And for Orsiro, it's 2.25 up to 4.0. And then the lengths for Orsiro, anywhere from 9 up to 40 millimeters in length, which is the longest stent that is currently available. And then the max expansion diameters, which is important and a practical point for the Orsiro, is 2.25 to 3.0. For the 2.25 to 3.0 stents, 3.5 millimeters in diameter, and for the 3.5 and 4.0, up to 4.5 millimeters in diameter. So what I tried to review with you today are some of the unique attributes of the Orsiro platform and potential indications for it. It's an ultra-thin, the thinnest drug-eluting stent that, because of this, makes it exceptionally deliverable and conformable, and certainly the clinical data attest to its deliverability, its safety, and also its efficacy. And although we have very good devices, thin strutted stents with either durable polymers or, in the case of Synergy, a biodegradable polymer, I think the Orsiro clearly is unique and will have a significant role to play once it's approved here in the U.S. As we look at indications and the stent platform itself, what I've tried to focus in on today is what are the indications that we have for the devices we have today, and I suspect for Orsiro, that indication is going to look quite similar to what we see today. Many of the lesions that we treat today, and I would say the majority, don't really have an indication. We're treating bifurcations, left main disease, very long lesions, etc. I think the indications that we'll see will not be particularly different. I also tried to review with you some practical information with respect to the advantages of the Orsiro platform as well as the practical day-to-day attributes that help you choose it or choose another device for a given lesion. At this time, I'm going to turn it over to Dr. Waxman. I want to thank you all for your attention.
And thank you, Dr. Hermiller. Hello, everybody. I'm Ron Waxman. Here are my disclosures. My goal is speaking to you today is to identify various patient subsets and best treatment options based on the lesion type, disease state, and patient presentation. In preparation of this presentation, I was assisted by Dr. Evan Schlomfitz. For the past 40 years, we have seen a dramatic evolution in the stent technology. It was started with bare metallic stent. Then we recognized the limitation of this technology, and we developed the drug-eluting stent with the first generation. Primarily, these were paclitaxel-eluting stent and sirolimus-eluting stent, Taxus and Cypher. And now we are in an era that we have the second generation drug-eluting stent, including Xience, Elunir, Synergy, Resolute, and Orsiro. In order to tailor the stents to a patient, we have to understand the patient considerations with respect to their clinical presentation, the patient's comorbidities, and complex lesions. With respect to the clinical presentation, there are primarily stable angina, ACS, which could be STEMI, non-STEMI, and unstable angina, and cardiogenic shock. Many of our patients have comorbidities such as diabetes, elderly, high bleeding risk, renal disease, low ejection fraction, prior cardiac surgery, atrial fibrillation, and frailty. And there's a variety of complex lesions that we have to treat, ranging from left main, calcification, bifurcation, CTO, SVG, In-stent Restenosis, long lesions, and thrombotic lesions. Some of those considerations we will cover during this presentation. Let's move to the clinical presentation. About 1.6 million hospital admissions are ACS annually in the U.S., and of those, 1.24 are unstable and non-STEMI cases. Primarily when we have to deal with patients with primary PCI, we are already agreed that we are going to treat them with drug-eluting stent. There is very little room anymore for bare metallic stents. There are some other considerations that we should look into. One of them would be the access, radial versus femoral. Radial approach may result with less bleeding complication. And with respect to the pharmacology therapy, we have moved from clopidogrel to ticagrelor and prasugrel, a second generation antiplatelet therapy, and most recently we also introduced to the cath lab, specifically for patients with STEMI and thrombus, Cangalor. There is a lot of controversy about thrombus aspiration. It's actually downgraded by the guidelines, but it's still heavily used, especially when you do have a TIMI zero flow. Some of us still utilizing direct stenting for STEMI patients. And then if patient hemodynamically compromised, we would use mechanical support devices. And we are following the door to balloon time, and most recently there was a new concept that was introduced, door to unload. Patients who present with MI may have multivessel disease. Apparently it is reported between 40 to 50% of the STEMI population. And there are three directions to treat those patients. You can go aggressively, and then you'll do multivessel PCI acutely. You can go with intermediate approach, which is going to be the non-IRA stage, and you can go also with a conservative medication for this population. One thing that can assist us is the use of FFR, and we can do the revascularization based on angio or based on physiology studies. One step further is those patients who presented with acute MI, which is complicated by cardiogenic shock. On those, we have different treatment options, which all of them are in controversy because they have not been proven to be effective in randomized clinical trials. Pharmacology, balloon pump, Impella, and ECMO are heavily used more and more, but again, the overall mortality of those patients who present with cardiogenic shock has not been improved much, somewhat because of the complication that resulted from the use of the more advanced devices like Impella and ECMO. We also have to distinguish that those devices, primarily the balloon pump and the Impella, still utilized for high-risk PCI, and lately we've seen growth in the utilization of Impella, and the threshold to treat those patients with high-risk PCI with Impella has been lowered, and we see more and more Impella use in the cath lab, not only on the context of cardiogenic shock, but also on the context of high-risk PCI. With respect to the patient comorbidities, all of them are listed in this slide. I think we have to understand that this patient population can pose some other risks as we treat those with different devices and obviously with drug-eluting stent. Let's start with diabetes. 9.3% of the U.S. adult population has diabetes, and the prevalence of diabetes has been increased above 25% in elderly patients above 65 years. Diabetic patients are at increased risk for death, MI, and following PCI. And there is a controversy whether those patients should be treated with PCI or CABG. The head-to-head randomized trials between CABG, PCI, Freedom, and most recently Syntaxis 10-year in the diabetic group did show that there is overall advantage of having CABG for those patients, especially if they have 3-vessel PCI needed in the context of diabetic patients. But again, the data is in controversy. In this slide, you can see that the all-cause mortality for diabetic patients was not statistically significant. Nevertheless, I think the threshold to send patients with diabetic to CABG is very common. And with respect to the stent technology, there are only 3 stents that are approved in the U.S. right now: the Xience, the Resolute, and the Synergy. All of them have indication also for the diabetic population. Orsiro currently is not approved in the U.S. It is approved in Europe, and it does also have in Europe an indication for diabetic population. And the data for Orsiro showed that most likely it would follow through with the indication for diabetic as well. What about kidney disease? We definitely seeing patients that do have renal function impairment, and in order to mitigate the further deterioration in the renal function, we're focusing on hydration strategies, either oral or IV. We're also recommending utilization of IVUS to minimize the contrast use, which is probably the key to spare those kidneys. And again, there is different level of evidence to the guidelines with respect to the level of hydration. But one thing that we can do is definitely minimize the contrast use for those patients. As we move to another patients, which is more the frail patients and patients who are at high risk for bleed, there are many patients that fit into this category. In general, every patient who is above 75 years of age is at high risk for bleed. And also patients with comorbidities such as renal disease, liver disease, and active cancer. These are patients that are prone more to bleed. There are also hematological factors and bleeding history for those patients, and procedural-related factors such as pharmacology that is used during the procedure. So why we care about it? Because the higher the risk for bleed, there is higher increased risk for mortality. As a result of that, there has been algorithm for DAPT duration that has been developed to minimize the duration to 1 month and 3 months. Currently, the guidelines advocate that for stable CAD, 6 months would be sufficient. In Europe, it's even 3 months. There are different scores that has been developed for bleeding and for ischemic, and I think once you follow those algorithms, you can see that you can minimize the duration of the DAPT. There are ongoing studies right now for 30 days and 3 months that will give us the final answer whether it is safe with the current DES to reduce the DAPT to 30 days. There are already studies that has been published with drug-coated stents that actually did show that when compared to metallic stents, bare metallic stents, there is no disadvantage to reduce the duration of the DAPT to 30 days. I'm referring to the BioFreedom and the Leader-Free 1 and 2 studies. With respect to the lesion type, I think for most we need to understand the morphology of the lesion. Calcified lesions posed a challenge in terms of deliverability of the stents and also expansion of the stent. It is pretty common. We see in 38% of the lesion some degree of calcium, and overall, if it's whole circumferential, it may require not just vessel preparation with balloon or scoring balloon, but also with atherectomy devices. The ones that are available in the US right now are rotational and orbital atherectomy. And in the future, we may use also intravascular lithotripsy, which shows some interesting results in studies that has been conducted overseas. Obviously, high-pressure balloon can be helpful, but can be resulted also with dissections. So clearly, calcified lesions are a challenge for treatment. Long lesions, I think the longer you stand, the longer the chances for restenosis and thrombosis. You have to focus more on vessel preparation. And also, there is a nice study that shows that if you do IVUS-guided imaging for long lesions, you would reduce the event rate. That was shown in the IVUS XPL study, which shows that IVUS guidance reduced the overall MACE. In-stent restenosis, despite the advancement of stent technology, is continued to be flat on 10% of the PCI in the US for the past decade. And that's because some of those DES first generation and even second generation had late recurrences of in-stent restenosis. We have to understand the morphology of the in-stent restenosis that can be done by utilizing of OCT and IVUS. And for the treatment algorithm, we can start with high-pressure balloon or scoring balloon. In the US, we don't have drug-coated stents, which balloons that are being used primarily in Europe. So what remains for the US is additional DES. Some people do laser atherectomy and also, obviously, vascular brachytherapy. Some of those patients, we have more of the recurrences, they may subjected to cabbage. With respect to intermediate lesions, these are the ones we're not sure to intervene or not to intervene, and that's where Physiology-Guided really comes to our help. We have a kind of algorithm that tells us that if it's an intermediate lesion, we should use FFR. If it's a severe lesion, we don't need the FFR. And what is severe lesion? It's more than 90%. Mainly we're using between 70 to 90 the FFR guidance or IFR guidance. There's a lot of systems that has been emerged that helps us to determine whether patients with stable angina should be intervened or not. And with respect to unstable angina, again, there is more and more evidence that you can utilize FFR to the non-culprit lesion to make the decision whether to defer the PCI or perform the PCI. Physiology also helps us when we have tandem lesions. This is more applicable to diffuse lesions or multiple lesions within the same vessel, and IFR seems to be the most helpful physiological device to determine whether you need intervention or not. Multi-vessel disease is also a challenge. We tend to calculate the syntax score and to follow the algorithm that if the syntax score is less than 22, we can still do PCI for 3-vessel disease. There is a question about the intermediate score, 23 to 32, and we may alter the scoring by using FFR. And when it comes to scoring more than 32, the guidelines pushing us to go for CABG with class 1 level of A, which is basically tell us those patients probably will do better off with CABG. Bifurcation, we think that they account for 15 to 20% of all PCI. We tend to use the Medina classification as illustrated in this slide. And there are different treatment approaches. Primarily what's most popular is to do provisional stenting, but if you need to use 2 stents, you would take one of those system or techniques that you feel comfortable, DK crush, mini crush, T and protrusion, which is called TAP, Culat, provisional proximal optimization, usually followed most of those procedures, and also simultaneous kissing stents. So again, a lot of the techniques here, but in general, if you have a very significant diseased side branch, you should consider 2 stents approach. If you have a very small side branch or no disease on the side branch, you may get away with provisional stenting. Left main disease also has been controversy. There are several studies, Nobel and Excel has been shown us that that can be done. And again, you may get more revascularization, but no much differences in terms of death, stroke, and AMI. There's also difference on the location of the lesion within the left main. The ostial body are easier to do and associated with better outcome compared to bifurcation or distal. And again, if we look at the guidelines does tell us that in the U.S. it is goes also with the syntax score, but we are looking on class 2A level evidence of B for PCI. With respect to European guidelines, they are more permissive. When you have a syntax score less than 22, it's a class 1 level evidence B for PCI, and class 1 level evidence B also for CABG. So this is where they equalize, but for all the other complexity, there is a tend to go more for CABG than for PCI according to the guidelines. Saphenous vein grafts are still common, and they account for 6 to 10% of all intervention. It is associated probably with doubling of the MACE, primarily because of no-reflow and some debris that goes downstream, also restenosis. And as a result, we recommend to use filter device, and there also have class 1 indication, although I must admit they are not much utilized in U.S. practice. We also need to recognize that many of the lesions that we're seeing are thrombotic lesions, which can be resulted with no reflow. How do we approach the no reflow other than stenting, which could be effective from the mechanical approach? We can consider aspiration and embolic protection devices, and there is also a lot of pharmacology approach that can be utilized for those patients. When we move to CTO, case selection is really important. We should demonstrate that those patients would benefit from opening of the CTO, and this algorithm really tells us whether those patients should be treated, whether CTO is indicated, whether it should be treated medically or should be treated by CTO, and that depends again a lot on those functional tests that should be done using CT and nuclear medicine to determine whether CTO is indicated. Once it's indicated, we have several approaches. Everybody is in agreement that we should do dual injection, and then some people are advocated to start with antegrade, give it first a try, but if it doesn't work, it should be done retrograde. I think with the recent advancements of wires and equipment, we have been reaching over 80% success rate, in some institutions even 90% success rate of CTO. But again, those procedures require a lot of patient skills, some more radiation and contrast. So we have to be very careful when we select the patient, the strategy, and be proficient in performing CTO procedure. So to summarize, this was a review of the patient consideration and lesion consideration for those who needs to undergo PCI. I think there was a lot to cover here, but it just tells you that it's not one size fits all, and you really have to take all those considerations of clinical presentation, the comorbidities of the patient, and complex lesions when you tailor the right stent and the right strategy to treat those patients. Thank you very much. This concludes this presentation.